Hello, good morning, good afternoon, and good evening to all of you who have joined from different time zones. A warm welcome from Sri Lanka to this webinar, Innovations in Clinical Development South Asia Forum 2021, hosted by the University of Kelaniya, Sri Lanka, and its research partner Remedium One, in collaboration with the Duke NUS Graduate Medical School in Singapore. Thank you for being here today. Before introducing the first speaker for the day, I'd like to inform that all attendees connected virtually are encouraged to use the chat box appearing on the Zoom application in order to forward their questions with regard to the discussion. All type format questions will be moderated and sent to the panel. May I also request all resource persons to kindly keep the time. Our first speaker is Prof. Asita De Silva.
Thank you very much. Good evening, ladies and gentlemen. I am Asita De Silva. I'm a clinical pharmacologist and a clinical trialist living and working in Sri Lanka. At present, I'm the senior professor in our university medical school at the University of Kelaniya, and I'm also the director of the clinical trials unit, which was founded in 2005 in collaboration with the University of Oxford and our research partner, Remedium One. The clinical trials unit was established with the approach of conducting large-scale population, clinical, and health system research with a focus on developing innovative, cost-effective, and scalable healthcare solutions in collaboration with centers of excellence with an interest in major NCDs and neglected tropical diseases. The South Asia Forum on Clinical Research and Innovation is our brainchild. We usually have this event as a biennial conference, but unfortunately due to COVID restrictions, we have organized this exciting webinar with the participation of some excellent resource people from Duke NUS Graduate Medical School in Singapore, London School of Health, London School of Tropical Medicine Hygiene, Aga Khan University in Pakistan, ICDDR Bangladesh, World Bank, WHO, and public health experts from the Ministry of Health in Sri Lanka. We look forward to your active participation. And in order to kick off this webinar, I just want to take a few minutes to introduce the focus of this webinar, high blood pressure. We all know that raised blood pressure is the biggest contributor to global mortality, accounting for about 18 million deaths each year. Unfortunately, 80% of which occur in low middle income countries. It is also the largest cause of disability adjusted life years, which includes about 7 million premature deaths. Again, low middle income countries disproportionately affected. In South Asia, where we live, this problem accounts for about a third of age standardized deaths, and the disease rates are seen, higher disease rates are seen at younger age groups with a greater loss of productive life years with serious economic consequences. This is the global cascade of hypertension care. Global context, high income and low middle income countries in terms of awareness, treatment, and control. Unfortunately, as you can see from the global panel, less than 50% of those who have hypertension are aware that they have hypertension. And as a result, probably, the level of control achieved among those who are treated is about 13.8% globally, and an abysmal 8% in low middle income countries, which probably accounts for the estimated 20% of global deaths attributed to non-optimal blood pressure, which is estimated to be growing at about 2% each year. Now, there's widespread belief at some point that rural communities, especially in low middle income countries, are less challenged by cardiovascular disease morbidity risk. This study, done by Salim Yusuf and his colleagues in US, the 5-continent meta-analysis study, which evaluated cardiovascular disease risk and events in high, middle, and low-income countries, covering both rural and urban populations, showed otherwise. What I'm showing here is cardiovascular disease risk, quantified as the mean inter-heart risk score for high, middle, and low-income countries, both in terms of urban and rural populations. And as you can see, cardiovascular disease risk incidence is highest in high-income countries and lowest in low-income countries with not much of an urban-rural divide. However, when it comes to cardiovascular disease outcomes, in terms of myocardial infarction, stroke, heart failure, all cardiovascular disease, the problem, the outcomes are highest in low-income countries and least in high-income countries. And if you look at the urban and rural divide again, the problem is similar. Cardiovascular event rates are highest, as you can see from the top panel, are highest in low-income countries and lowest in high-income countries. And if you take case fatality rates, the lower panel, you can see again the same pattern where the case fatal rates due to cardiovascular disease, the lowest in high-income countries and highest in low-income countries. And in addition to this, alarmingly, in low-income countries as well as middle-income countries, the problem is more toward against rural populations. So what I'm trying to say here is that although the risk incidence is greater in high-income countries, the events and fatality rates are greater in low-income countries, and again, rural populations being disproportionately affected. Which is why this pivotal study, which we're going to focus today during this webinar, which will be presented to you by Professor Tahsin Gaffar from Duke University Medical School, Duke NUS Medical School in Singapore, is we selected as a focus today this pivotal trial which we conducted in these rural Bangladesh, Pakistan, and Sri Lankan population with overall collaboration and coordination from Duke NUS Medical School. But before I request Professor Tahsin to take over and present this study to all of us, I'd like to show you a short video clip which we prepared for the study in Sri Lanka. Sri Lanka is an emerging country in South Asia. It has 21 million population, and recent data indicate that technically 1 in 3, 1 in 4 people have high blood pressure.
Hypertension is a big problem in the Puttlam district also. There are so many people who are not taking treatments.
Funded by the UKMRC, Wellcome Trust and DFID, the project is coordinated at the Duke NUS Medical School in Singapore and is conducted at 3 countries, Sri Lanka, Bangladesh and Pakistan. And a peculiar problem in this population is that they get these illnesses prematurely, so much earlier than any other population, and therefore needs immediate attention.
The project that we are participating with funding from the Wellcome Trust and the Medical Research Council in the UK.
Cobra BPS is a multi-component intervention program. Public health midwives going door to door for blood pressure monitoring and delivering home health education. Those with high blood pressure are referred to specially trained physicians.
We're seeing about, of the 850 participants from Sri Lanka, almost 80% already were hypertensive.
And patients monitoring, tracking and follow-up are key features of the program.
The estimate is that about only 25% of the people who get treatment achieve their blood pressure targets. Now that's a major problem.
The countries now need to work with their governments and other key partners and work on scaling these interventions up, which is, I think, is very, very important, and to bring them up at a national level. And the Cobra BPS provides an excellent platform of showing how NCD care can be delivered in the health systems.
I personally believe, as an investigator in the study, that delivering this home health education program, the multi-component intervention, which you have taken to the community, and if the results show greater value in managing blood pressure on top of standard of care, I think this should be scaled up and implemented across the country.
And we've also identified a number of comorbidities like diabetes, kidney disease. Delivery of these conditions and diseases can be integrated within the same platform, and they need to be evaluated and then eventually scaled up and will lead to saving many, many lives and reducing disabilities across South Asia and other countries.
And now, great pleasure in introducing Professor Tahsin Gaffar to make a presentation on Cobra BPS and take this discussion forward. Professor Gaffar is a professor of health services and systems research at Duke NUS Medical School in Singapore, a visiting consultant renal medicine Singapore General Hospital, and professor of global health at Duke Global Health Institute at Durham, USA, and chronic disease epidemiologist as well. She has more than 15 years track record of leading community-based trials on hypertension, including the large multi-country trials, and chief principal investigator of the control of blood pressure and risk attenuation, that is Cobra BPS trial in South Asia. Tahsin, it's my great pleasure to invite you to start your presentation and take this webinar forward. Thank you very much. Over to you, Tahsin.
Thank you. Thank you so much, Professor Sita. First of all, I'd like to extend my warm welcome to everyone, all the speakers, all the panelists, and so many participants who've joined us from so many countries. I think we have participants here from 20 countries who've joining us on the webinar, which is absolutely fantastic. So a very warm welcome to everyone. And as Professor Sita very nicely has given a very nice background of the reason for having the forum, we're going to be discussing our hypertension control and other NCD control programs. And we hope that this is going to stimulate dialogue among the stakeholders. We are starting off with, in this forum, we're taking this opportunity, starting off with Sri Lanka. We hope that our next seminars that we're having for Cobra BPS, we're going to have with our stakeholders in Bangladesh, in Pakistan, and also I'm hoping in other South Asian countries, India, Nepal, and other low and middle income countries where we think that these strategies are going to be adaptable, with some modifications. So we really hope to engage other stakeholders in other countries, and also grateful to the participation of our colleagues from WHO here today, Dr. Gaffar, who's going to be one of our discussants, and of course to Professor Shaibrahim for being the moderator. So with that, I'm going to, let me share my slides. So as, again, Asita has already started alluding to the exorbitant burden of hypertension. These are data from the very recent data from the Global Burden of Disease 2019. And unfortunately, high blood pressure continues to be the leading attributable risk factor for mortality. So here, this panel here shows the, I'm going to turn the mortality risk factors for mortality in women, and you can see high systolic blood pressure is a leading attributable risk factor for women, and in men it's number 2. It comes after tobacco, and together in 2019, high blood pressure was responsible for 10.8 million deaths, which total together account for 19% of all deaths. And it's unsurprising because hypertension, in fact, affects about 1.4 billion people globally, right? And this number is escalating every day, unfortunately. And the control rates for hypertension. So prevalence is very high, awareness is very poor. I'm not going to go into the details, as Sita mentioned, alluded to this already. Control is very poor. And if you look at the urban-rural differences, in pretty much, in upper middle income, low middle income countries, you'll see is overall less than 20%, but especially poor in the rural areas, less than 10%. We are looking at figures at 5 and 4%. And these are data from the PURE study, again. And so very, very poor control rates, especially in the rural areas. So this poor control rates have very serious implications for the rural areas where, we've again seen the data that the case fatality rates are really bad in the rural areas. And partly because clearly, people, when they get a heart attack, there's no access there. You cannot take them to the hospital for angioplasties, for reperfusion therapies. Majority of deaths still in rural areas in South Asia, unfortunately, are at home, and health systems are weak. No ambulance services, etc. And so it's the risk factor control is very important. High blood pressure, huge problem in the rural areas. And then furthermore, South Asians are at heightened risk of cardiovascular disease, and that starts at a very early age during the life course, even the preconception area. This is beyond the scope of the talk to talk about the higher risk in South Asia, but there's lots of literature now on the higher risk. In fact, South Asian ethnicity is now itself recognized a risk factor for cardiovascular disease. And not only that, it occurs at an earlier age. And so the point here that I'm trying to make is that interventions are needed for prevention and control, especially in low and middle income countries, especially in the rural areas, and particularly in the South Asian region. Also in the other regions, but particularly in the South Asian region. And that's what motivated us to work more in South Asia. Now, as far as the previous literature is concerned, we've done some trials. Our first trial that we did at the health systems level, looking at health system solution. So we evaluated the model of training community health workers and training physicians, and different types of models, training community health workers alone, training physicians alone, training a combination of the two, so different combinations. And what we found was that when you train the two together, right, combine dual strategies, is going to work effectively in lowering blood pressure. Single isolated strategies were not more effective than usual care, but combining the two strategies was effective in lowering blood pressure in urban Pakistan. We did the study, reported in the annals. It's been about a decade that we reported this now. We also showed that it was going to be more cost effective. Subsequently, there are other community health worker-led models in urban areas. It's been shown in Argentina, in Nepal, in Malaysia, Colombia, other places in India. So there's a lot of literature on community health worker, 30-odd studies now on community health-led models of hypertension care in the region. The issue, that we have is that predominantly these trials will be done in urban areas. And the other problem is that the community health workers in these trials were not part of the existing public health infrastructure, so not government community health workers. They were mainly recruited for the trial. And these standalone models, the issue with them is they're not sustainable or scalable, right? So they're very resource intensive. So their fit and effectiveness in the rural setting and their scalability in the rural setting using the public health sector or infrastructure was not clear, right? And so now we wanted to come up with models that are scalable, sustainable in the long run. So with that, to answer that question, we then designed, and that was a motivation to evaluate this control of blood pressure risk attenuation in rural communities in the 3 countries. You want to see not just in one country, but what is it going to be in the region and other countries also, that type of model. So with that was our motivation to do this trial, the multi-country cluster randomized controlled trial, and I'm going to be sharing the results with you. It was funded by the MRC Wellcome Trust, DFID. And the main objectives were to determine whether in rural Asian communities, a low-cost, highly scalable Cobra multi-component intervention facilitated by community health workers who were already part of the existing public health infrastructure would be more effective than usual care in lowering blood pressure among adults with hypertension. We also want to determine the budget impact analysis and the incremental cost effectiveness analysis of the above mentioned program. Because again, cost effectiveness and budget impact, and my colleague, Professor Eric Finkelstein, is going to be discussing the results of this. And again, this is going to be key in every study that we do, because we can do effectiveness, but if you don't do the cost effectiveness and you don't do the budget impact analysis, then it has very little meaning to the policymakers. So this bit is extremely important in the trials. And then we looked at, we formed a number of qualitative aims. We looked at the barriers and facilitators, and those were essential to even inform the strategies that we built. So we did a lot of this pre-intervention to modify our interventions. And then we assessed acceptability before the intervention, during the intervention, and after the intervention, using the theoretical framework for acceptability. And my colleagues in the site principal investigators and co-investigators from Bangladesh and Pakistan and Sri Lanka are going to be discussing the results of the acceptability with you during our panel discussion today. So the trial was done in 30 clusters, 10 each in Bangladesh, Pakistan, and Sri Lanka. This is a randomized controlled trial. And so such that 15 clusters were to usual care and 15 went to intervention, and 5 and 5 in each of the country. And another feature of the trial, which is very peculiar, was that we also stratified not only by country, but also by distance to the government clinic, because we were particularly also interested in seeing what happens, what will be the intervention like in the clusters that were actually very far and very remote from the clinics. So does it really reach out to the very, very rural, remote populations? And so we stratified it. So 40% of our communities in each of the country were far clusters, right? So that's how the randomization went. And then these are our 5 components. I will discuss in detail the 5 components in a minute, but the details you can find in our protocol paper that's published. We have a statistical analysis plan paper that is already published. It was a pre-published before we started the analysis. And then we have a feasibility study. And these 5 components that we came up with were really the conceptual framework was derived from the urban study that we did before. And then the feasibility study. The feasibility study was also done in the 3 countries in the rural areas where the dual strategy of community health worker and trained GP was defined. And we then came up with the 5 components that are listed here, and I'm going to be telling you in a minute. And then we had independent outcomes assessment. So a team of outcomes assessors. It was not the same team that was delivering the intervention, which is the strength of our trial. They assessed the participants in both the intervention and the usual care clusters every 6 months. And the final follow-up visit was 2 years. And with the Omron devices, measuring blood pressures and also assessing morbidity, mortality, as I will be mentioning. The first component of the 5-component intervention was community health worker-led blood pressure monitoring and stepped-up referral. And Asita showed you a photo of the public health midwife. This is what it was. This was embedded in the existing public health, publicly funded program in every country. So each of the country has a community health worker type program. They're called health assistants in Bangladesh, lady health workers in Pakistan, and public health midwives in Sri Lanka. And they at this moment their mandate is doing maternal child health services. They routinely do not do any NCD work. So we trained them in measuring blood pressure. We gave them an Omron. We trained them in measuring blood pressures and then filling out a standardized checklist, which is what they did. So they went door to door and did blood pressure monitoring. And then they're also referring the patients with very high blood pressure to the clinics. We also trained them in home health education. This was a very standardized training and in nutrition and lifestyle curriculum. And then we also trained them in behavior change communication strategies. The nutrition curriculum was based on a DASH type diet, high in fruit and vegetable intake, low fat, dairy products, whole grains, low in salt, and then of course maintaining ideal body weight, increasing physical activity, smoking cessation, and moderation in alcohol. And again, this was delivered at every 3 months or 4 months in Bangladesh. And this is, and the key thing here is when the community health worker went to the household of the hypertensive individual, all the members, this was a family base, so all the members, and so in some households where there were kids, they would also gather around. And so there are the benefits of this obviously are going to be much beyond hypertension control, right? And so I think that's the point here. So So that's what, this is how the home health education was delivered, and then they filled out a checklist of what they did. The third component was training physicians. The physicians at the primary care centers were trained in blood pressure measurement, lifestyle, and then also in management, when to give first line, second line, third line therapies, and when to start statins. And this was based on at that time, the JNC8 and the 2013 European Society of Cardiology guidelines. They were prescribed generic antihypertensive. We encouraged them prescribing generic antihypertensive medications and statins. And the target blood pressure was less than 140/90 for all. Just kept it very simple. One target BP for everyone, even for those with end organ damage, which at that time was debated. So training was carried over 1 day for 4 hours, and then they were trained retrained in 3 months, and then annually. And then the fourth component was a designated triage counter and a care coordinator. And these triage counters were kind of a reception areas, basically, and the care coordinator was sort of a person who would track referrals and would liaise with the community health worker supervisor. And this was the triage counter was the suggestion for the triage counter was actually, it came from the district managers themselves during a feasibility study. And we listened to them because there were some reservations whether we should have this or not. And then we eventually decided to keep them. And Bangladesh already had the NCD corners, and we converted the NCD corners into use them as the reception areas. And the fifth and the final component was a financing model to compensate for the additional services. So whatever these community health workers were doing in addition to their routine duties. And we counted the hours. So it was about 20% additional workload for them. And these additional workloads, we then compensated. We gave the same amount of funds to the district system. And then it was up to them whether they wanted to recruit additional manpower or they wanted to give the additional funds to the people who were doing the work as compensation for additional work. We're not calling it incentive, and maybe Eric can talk more about it. But that's not what we're calling it. This is clearly compensation for our additional work, because again, we are looking about scalability and sustainability. And I'm not going to talk much about targeted subsidies. We wanted to introduce vouchers for eligible patients who were had very elevated blood pressures and were very poor, and we left it to the sites to do means testing. But this component could not take up well because they couldn't create accountability mechanisms to ensure that money was going in the right hand. So less than 2% uptake. So this component, but I do want to mention that we initially wanted to evaluate this, but this one didn't go well. But this one, we had 100% fidelity with the CHW compensation. So 2 years, we had a excellent follow-up rates. This is, apologize for the small font. It's a big study. So at the end of 2 years, usual care, we had 89.3% follow-up rate, and intervention, we have 92.1%. So excellent follow-up rate in both the groups, which was better than what we'd expected with being in a rural area. And these are the baseline characteristics of the individuals, and really very 70% had uncontrolled blood pressure. There was a lot of diabetes, 1 in 4 almost. There's a lot of obesity, considering that this is a rural area. And although it's not shown here, but I must mention that as there's a lot of kidney disease, especially in Sri Lanka, there's a lot of kidney disease. And our participants from Sri Lanka would be aware of this as well. And it was uniformly found, and we've published papers on this, found in every single cluster where we were. So again, that's something that is a comorbidity that I think we will probably need to address, and we started thinking about. So at the end of 2 years, these are our outcomes. So our primary outcome was change in systolic blood pressure. So here you can see that on the y-axis, we are showing a change in blood pressure here, right? So 0 - 2 means that a decline from baseline to follow-up by 2 millimeters. So this is the decline in blood pressure here. The red line is for the control group. The blue line is for the intervention group. So blood pressure declined in both groups. But the decline was greater, as you can see, in the intervention group, and the curve separated after 12 months. And then they seem to widen with time, right? And the same thing here with the diastolic blood pressure. And at the end of 2 years, this difference was was greater by 5 millimeters. So it lowered more by 5 millimeters of mercury in the intervention group than the control, which is quite substantial, considering that even 1 or 2 millimeters can be difference in systolic blood pressure leads to about 7 to 10% decrease in cardiovascular disease. And this is our other key outcomes. So this is controlled blood pressure was greater in the intervention. This is the difference, risk difference. So it is better by 22% people with controlled blood pressure in the intervention group. This is change in dose of antihypertensive medications. So antihypertensive medications, the dose went up in the intervention group. And this is quality of life, which also went up. So it improved in the intervention group, which is in surprise in the sense that, when you prescribe antihypertensive medications, you expect some side effects and whatever. But here we are observing that clearly the quality of life improved, which is a positive thing. These are a subgroup analyses for our primary outcome, which was change in systolic blood pressure. Here is the overall effect of -5. And there was no interaction by country, which means, and we were powered, I'm not showing you the power calculation, but we were powered to look at substantial differences among countries here. And this interaction test was negative. So this is clearly indicating it was equally effective in the 3 countries by distance, by gender, by the socioeconomic status. It was more effective, seemed to be more effective, obviously, in individuals with very poorly controlled blood pressure, systolic more than 160, diastolic more than 100, which is not unexpected. So safety outcomes, again, so these are just chi-square tests. These are not model. What I previously showed you were based on our GE general estimation equation, but these are just chi-squares. And so we had the death rate was lower in the intervention group compared to the control group. This was pre-specified. And not quite, it's almost 0.06, but it was lower here. And then this is death from cardiovascular disease. Was definitely lower in the intervention, but the caveat here is this is a post hoc. We did not pre-specify that we'd look at death from CVD because this was a rural area, and there is the cause-specific mortality in the 3 rural sites. We weren't sure how robust those data were going to be, although we had in each of the country, we had a mechanism of data adjudication. And I think we did as good as anybody can do. So each of the deaths was reviewed by multiple physicians and educated by at least 3 of them and reviewed. And then at the secondary level by us, the data coordinating center. And so this is how it was done, but we did not pre-specify it. At any rate, it's what it's indicating is indicating in favor of the intervention. And I think that's the important point here. So we conclude that a multi-component intervention tailored to the rural setting delivered over 2 years through the public existing public health infrastructure significantly reduced systolic and diastolic blood pressure and improved blood pressure control compared to usual care and adults with hypertension in rural communities of Bangladesh, Pakistan, and Sri Lanka. The intervention also increased antihypertensive medication use and improved some aspects of self-reported health. The intervention effect increased over time. So we saw that indicating longevity of the benefit. And I think that's important to bear in mind. Also, when we design, a lot of people are designing new studies and thinking about step wedge designs and other designs. And I would just bear you that I think we just need to bear in mind that here we've now documented that there is a longevity of benefit here. So, and then, as I've said, even the 5 millimeter that we observed, even a 2 millimeter decline in blood pressure has been associated, and there's loads of literature systematic reviews associated with 7 to 10% reduction in risk of coronary artery disease, stroke, and mortality. So I think that we believe our data are robust and will lead to substantial declines in morbidity and mortality. Now, community health workers are an integral part of the primary healthcare infrastructure for successful delivery of maternal child care in South Asia and many other countries like China, Vietnam, Mexico. And so our model, I think, it can be adaptable and has implications for a lot of other countries. And I think if it's scaled up in South Asia and in other countries, it is likely to translate into substantial reduction in premature deaths and disability, as well as in social and economic gains. And you'll hear more about the economic aspects of it in a minute. Some economic, the affordability aspect of it in a minute, but it will lead to tremendous gains. And once hypertension care is rolled out, a lot of people ask, well, how about diabetes? And I've mentioned myself about kidney disease. How about other disease conditions, mental health? I think once hypertension needs to be a point of entry, it is a majority condition. It is, as I said, we've seen the leading attributable risk factor for death. And it's something that we need to, that we need to can train. It doesn't, it's not invasive. You don't have to, the community health work, you don't have to train them in doing blood tests and other things. So I think this is a good starting point, an entry point for NCD care. I think once they are trained in, and we can know that the system we established this delivery care system, that other disease conditions like diabetes could be targeted and evaluated using the same platform. And also the same reimbursement model as we've just discussed. And then finally, the question about the timing of scale up. This is a very important time because individuals, about the pandemic itself, individuals with hypertension related end organ damage are at very high risk of complications and death from infections, including COVID-19. Therefore, I think it's even more important to start thinking about rolling up hypertension control programs now with safety measures. And then the number of a few existing initiatives, whether they are MOH-led, whether they are WHO-led, and we're going to hear about some of them today. There are policy-level initiatives, the SOLVE programs, and I think they're all good. But we need to have these evidence-based systems-level approaches for people who already have hypertension. And if there's a facility-based program, we need to ensure that we have the additional Cobra component so that we can have the 5-component program there, especially the community health worker-led health promotion and blood pressure monitoring for clinically meaningful blood pressure reduction and cardiovascular risk reduction at a population level. And so discussions for scale up right now are ongoing with the stakeholders. This forum that we are having right now is part of that process. With the government, with global agencies, including WHO, World Bank, industry, professional societies, the International Society of Hypertension, the ISH, in fact, has have helped us in publicizing the forum. Many members have actually joined the webinar today. So this is all ongoing, and I look forward to discussing with our partners. And finally, just thank to everybody who's from the ICDDRB, Aga Khan, University of California, and London School of Hygiene, and then our steering committee members chaired by Joe Perk, Data Safety Monitoring Committee chaired by Andrew Farmer, and of course our funders for letting this happen, and we look forward to ongoing support. So I guess that's it. Thank you so much. And
thank you again.
Yeah, and I think what we'll do is we'll probably take the question answers later.
Thank you very much for that. We have a few questions, okay. And most of them are related to challenges of scaling up and what we think about capabilities of community healthcare workers scaling up, and of course related to adherence of the medical program. Shall we take this at the end because we need to keep to time? And would you take the next session, introduce Eric to do the economic evaluation presentation?
Yeah, I think what we can do is we can take I think these are great questions, and I think we'll have a question answer session after my talk. Let me introduce, before Eric, Professor Shaibrahim, so he can moderate the session for Eric, and then let me introduce Eric. So I will introduce our next moderator and then our next speaker, Professor Shaibrahim first. So Professor Shaibrahim is an honorary professor of public health at the London School of Hygiene and Tropical Medicine in the UK. Professor Ibrahim has had an illustrious career in epidemiology and public health, especially in NCD. He served as a co-editor of the International Journal of Epidemiology and the founding editor of the South Asia Network for Chronic Disease. He's currently a member of the DBT Wellcome Trust India Alliance of Clinical and Public Health Fellowship Committee, and it was also a collaborator of the Cobra BPS study. So Professor Shaibrahim will moderate the sessions, the remainder of the session for us. And then my colleague, Professor Finkelstein. Professor Finkelstein is a health economist and a professor in health services system research at Duke NUS, where I am based. He is also the executive director of the Lane Center for Palliative Care and a research professor at Duke Global Health Institute, and has done some, I'd say, fantastic cost effectiveness analyses for Cobra BPS. So Eric, over to you, and Shah, over to you.
My task really is to present the budget impact and the cost effectiveness analysis associated with Cobra BPS. Now, unfortunately, our manuscript is under second round of review at a journal, so I'm only going to be able to present the results that were published in our New England Journal article. I won't be able to present the full results, but I'll at least be able to give you the methods that we use for the BIA and the cost effectiveness analysis, and hopefully very soon we'll be able to share some good news from the journals. But for the BIA, we looked at the first 3 years of the scale up costs from the health ministry perspective, and for the incremental cost effectiveness analysis consistent with guidelines, we looked at the health system perspective, including public and private payers. And we looked at the lifetime incremental costs and the lifetime incremental benefits to come up with a cost effectiveness ratio. And unfortunately, as I said, we can't share the full results right now, but hopefully you'll be able to see those pretty soon. But in terms of the methods, the assumptions for the scale up were basically, we tried to make it as close as possible to what would really happen. So we said, okay, we're going to assume that the health sector would scale this up to all areas in each country that have existing CHWs, which was 100% coverage in Bangladesh and Sri Lanka, and 60% coverage in Pakistan. And that we would reach all rural households within the first year, very ambitious, but we assumed that was possible. And we priced in that each CHW would carry a BP monitor, and that there would be administrators at the national, provincial, and district levels who would be required to oversee the scale up and whose time we would have to account for and price in. And as I said, we focused specifically on the public sector cost to the health ministry. How did we price it? Well, we used what's called activity-based costing. So we identified the key activities from Cobra BPS, and then within the trial itself, in real time, we tracked the key administrative, direct and indirect activities associated with either training providers or delivering community health worker-led education or delivering the primary interventions, including the medicines, and we costed it out. And then we also looked at any increase in cost that might result or decrease in cost from increased healthcare utilization, say perhaps increased use of BP meds, or if, for example, people got healthier and they used less medicine, then we would track that as well. So we had all of these tracked in real time during the trial. So we were able to come up with the incremental cost as well as any potential cost offsets. And consistent with the cost effectiveness analyses, we excluded research costs or any sunk costs that would not have to be repeated were the intervention to be scaled up. So that was our general approach. Now for the cost effectiveness analysis, we took the approach from the health system perspective, including any public and private sector costs, and we looked at the lifetime costs and benefits, because the truth is, if we identify patients with hypertension, they may end up being on antihypertensives for the rest of their lives, but they also may have increased or decreased life expectancy as well as changes in quality of life. So we wanted to account for those as well. And as Prof. Tazeen mentioned, there were differences in quality of life. Now, it turns out doing cost effectiveness analysis, the mechanics behind it, or at least the idea behind it, is actually quite simple. It's the incremental cost divided by the incremental effectiveness. Sounds very easy. The challenge is, how do you take something from 2 years and a clear estimate in improvements in systolic blood pressure and then convert that to lifetime improvements in CVD DALYs. Well, it turns out it's not trivial, but the way to do it is to use the algorithms that Prof. Tazeen mentioned that shows that for every 4-unit reduction in blood pressure, you can get up to a 10% reduction in CVD DALYs, right? And so we use those relationships to come up with our net CVD DALY and our net total DALY savings or DALYs averted associated with the BP reductions that we saw, and that would be our denominator, and our numerator was our net increase in costs, taking into account the direct costs associated with delivering the intervention and subtracting off any cost offsets from changes in health status between intervention and control. And then we compared the resulting estimates within each country to WHO benchmarks for cost effectiveness based on per capita GDP in each country. So WHO says if it's better than 3 times per capita GDP, it's very cost effective. If it's cheaper than GDP per capita, it's cost effective. So we compared our estimates to those values. Now, as I said, I can't show you the CEA results, but I can share the results that were in the New England Journal article. So when you look at the budget impact analysis, if you looked at the per participant cost, which is just the second to lowest row, what you find is that costs were $10.70 in Bangladesh, $10.50 in Pakistan, and a little bit less than half that in Sri Lanka. If you look at the per capita cost by taking the total cost and dividing it essentially by the number of people in each country, these are all in US dollars, you see that we're looking at less than 70 cents per capita per year. So fairly inexpensive, right? Now, so just to summarize our budget impact results, to scale this thing up, it would cost roughly $10.70 per participant in year 1, and actually slightly less in subsequent years or in future years because we have some economies of scale, or less than 70 cents per, or what was our number? Less than 70 cents per participant. And basically, if you look at the true costs here, you could achieve these benefits of Cobra BPS at a 10%, 3%, and 2% increase in budgets in the first year, respectively, for Pakistan, for Bangladesh, Pakistan, and Sri Lanka, respectively, in that order. CEA, as I said, is a work in progress, so I can't really talk much about that. In terms of the discussion section, I'm happy to take comments. My only point is that the same as Prof. Tazeen, just a little foreshadowing. In our New England Journal, we show that the paper was highly effective. In our manuscript that we hope to get positive news from soon, I think we make a pretty compelling case for cost effectiveness as well. So I will stop there, and hopefully there'll be some time for questions.
Thanks very much. One question that just struck me was this 50 to 70 cents per head population for this intervention. How does that compare with other primary care interventions that we consider to be absolutely fine? You know, vaccination programs, maternal child health interventions. Where does it rank?
Yeah, sure. Thanks, Shah. That's a great question. I would say that if you look at the WHO Best Buy interventions, we're in the mix. A little bit more expensive. Some of those are $2 to $3. Some are $5 to $6. So we're between $5 and $10. So a little bit more expensive, but not too far.
Okay, fine, thanks. I'd suggest we move on to the reflections on Cobra findings and panel Q&A. I've made a note of the questions that as they've piled up, but I'd suggest we start on with Professor Asita and Gunawadhana from Sri Lanka, and the team there, and I think we were going to get a series of small talks, if that's the correct situation. So why don't we kick off with the first one, and then I can introduce these succeeding teams. So if Professor Asita and Dr. Andari would like to kick off.
Yeah, thanks. Thank you very much for that. I'd like to ask Professor Anuradhani Kasturiratne. She's a specialist in public health. She's done a lot of work in Sri Lanka on hypertension, done some of the pivotal prevalence studies, to present to you some of the reflections that we have. Anuradhani, may I ask you to provide the feedback?
Thank you, sir. Thank you, everyone. It's a great pleasure to be here on this webinar. So I would like to quickly present some of the reflections from our Cobra BPS study in Sri Lanka. Okay, to quickly move through the fidelity of the intervention in Sri Lanka, we have shown high fidelity in the intervention. At the outset, we recruited 431 participants for this study, and of them, 98% of the participants received at least one home-based health education session from a community health worker. In this case, public health midwives who are already part of the health system in Sri Lanka. And out of these people, 38% qualified or were eligible to be referred to a primary care physician. And all of them were referred to a primary care physician, which was considerable. And about 70% of those who were referred actually had a consultation and completion of documentation at the primary care physician. So this we consider as very good fidelity, considering that the community health workers were not actually people who were delivering NCD care as routine part of their work. They were trained for this, and they did something above and over their routine duties. And this sort of high fidelity in referral, as well as good response from the clinicians at the primary care level. So this was shown in the intervention case. To share with you quickly some perceptions of the primary care physicians. The acceptability of having a public health midwife who is part of the system as the community health worker in this study was commended very highly by the physicians, because the acceptability of the person who is delivering the intervention will be very important to the people who participate in it. And a system where people actually are very close to public health services, having a public health midwife delivering these services is a bonus to the success of the intervention. They also commended a lot about the protocol, the Cobra BPS protocol, and how it's useful and applicable to their day-to-day practice, even in their routine work. That was commended by the primary care physician. So overall, the perceptions were very positive from the doctors. The community health workers felt empowered by being a part of this study. They, outside their routine duties, they were able to care for people in their communities through this study. And they also recognized the many socioeconomic and other barriers to access, like having a lack of carers and lack of access, sometimes due to socioeconomic reasons or distance. So in such situations, monitoring at community level and being able to refer to primary care physicians was very much valued by the community health workers who participated in this study. So these are some of the positive perceptions that we see in the intervention in our country. And however, in the phase of the current pandemic, I think scale up as well as delivery of routine services will change forever. And in the next slide, you can see what we anticipate. The next slide, yeah, we may anticipate something like this in future, where everything has to change and the healthcare services will be still delivered in a different way. And it has to go on even in a challenging situation like this. And even now the community-based work is going on. So we can expect something like this or something less severe. However, the services have to go on caring for people and making things better in terms of health care. Thank you very much.
Thank you very much indeed. Very good timekeeping too. Our next speaker is Dr. Alia Nahid. Alia is the head of the Initiative for Non-Communicable Diseases and Health System and Population Studies Division at the ICDDRB in Bangladesh, and she's a country co-investigator. Alia, can we have your presentation, please?
Thank you very much. Good evening from Bangladesh. So I will basically present the acceptability of Cobra BP strategy Bangladesh. So our program was introduced in 2 districts in Bangladesh, that is Tangail and Munshiganj. So 2 clusters from Tangail and 3 clusters from Munshiganj were recruited for this intervention. As Tazeen already described, the process of implementation was deployed by 2 groups of healthcare providers, the grassroots level community health workers, that is health assistants in Bangladesh. And these health assistants were supervised by health inspectors and assistant health inspectors. So they were trained and they offered home health education session in presence of their family members, as you can see in the middle of the picture. So family members at all age are gathering around the community health workers who is using a flip chart to come providing the messages. So those patients who were actually referred due to uncontrolled blood pressure, so they were referred to the NCD corner of the primary facilities that were linked to these 5 intervention clusters, as Tazeen mentioned before. These NCD corners are created by the government of Bangladesh in every sub-district hospitals throughout the country for providing services. And these corners were enhanced through the Cobra BP strategy. If you look at the lower right corner photograph, you will see that this is a nice room with a wall and with a table. We provided equipments like blood pressure monitoring device, that's Omron. And we provided them the posters that was developed by our Cobra BPS team for promoting lifestyle modification. And of course, on the right-hand side of the wall, we'll see a large picture of algorithm-based case management that the doctors were trained on. And they followed that algorithm-based case management when they are treating any patients, including the Cobra participants. So altogether in the 5 clusters, they belong to 5 facilities. We actually trained all the doctors, and a couple of them were designated for the NCD corners in the facilities to support Cobra services. And those were poor, they were provided subsidy, but interestingly, we did not find a lot of people who required that subsidy in our setting. The entire operation was built into the existing health systems. We tried not to deviate from the regular function of the government service. So we did very little change in the process. All we did is engagement of everyone from the top level down to the bottom level, such as the entire implementation was monitored and governed by an advisory committee that we call Cobra Bangladesh Advisory Committee, which was chaired by the Additional Director General of DGHS of the Ministry of Health, Professor H.M. Inayat Hussain. And this committee comprised of program managers, civil surgeons, and NCD control program health providers, and the research team members. And the committee was supported by the Director General of Health himself. So there is a strong political will for integrating Cobra into the existing health systems in Bangladesh. And as such, we were able to do a miraculous thing in the country, that is, we were able to push the government to provide NCD drug supplies all over the country, including these primary facilities participated in this Cobra intervention. So our targets were very well achieved, and more than 90% of the home health education sessions were delivered, and referrals that were made by the community health workers, more than 80% were attended by the doctors. So we got some champions in 5 multi-component intervention facilities. So we had triage coordinators who became champions. We have 106 trained doctors who now know how to use algorithm case management and offer the services wherever they are going at the moment. And we have very well-trained community health workers who are capable of going to households and determine pressure, blood pressure, and also provide lifestyle modification guideline. And as a result of this collective efforts of the very high level authority in the government and the grassroots level workers, we were able to demonstrate impressive reduction in systolic blood pressure and diastolic blood pressure in 2 years' time. And we have started seeing changes after 12 months. And the proportion of patients with high controlled blood pressure increased in the intervention areas compared to usual care areas. That was really impressive. But when we were implementing this strategy, so we were actually criticized that we would not be able to get engagement. But what we found quite different, because healthcare workers were very happy to be a part of it, and they felt empowered, and they also learned a lot to provide their services beyond Cobra BPS. And doctors found this process to be very helpful for the patients, bringing the medicine to the better supplies to the facilities, being atrovastate available. These were all viewed very positively, and patients benefited at the end of the day. Those are very much highly appreciated by the doctors. So apart from the trial—
Alia, you're running out of time.
Dr.
Alia, you are running out of time.
30 seconds. Apart from this participants' care, what we found, both the health workers and the doctors really extended their services to other people, and the services continued, and the medicine supplies were available. And we can claim Bangladesh is now ready to scale up Cobra BPS strategy countrywide. And I thank everybody, particularly the participants and our team members. Looking here, this is 2016 picture, and we all look very different at the moment. Probably want to change the country at the moment by introducing Cobra. Thank you very much.
Thank you very much indeed. Okay, we come to our next speaker, who is Professor Amir Hamid Khan. He is a professor of cardiology at the Aga Khan University Department of Medicine, and he is a country co-investigator in Pakistan for the Cobra BPS study. Professor Amir.
Thank you, Professor Brian. I'm going to go quickly. I know we are running over time, so we're going to have the perspectives of the enrolled patients, the healthcare providers, and talk about intervention fidelity. So, as we know, it's the same model. The stakeholders were the patients, the households, and then the trained general practitioners, the hypertension counter management, the CHW supervisors, and the CHWs themselves. And for the fidelity, there were 984 recruited for the study, and 450 were eligible for the intervention arm. BP monitoring and home health education was provided to about 97, and the checklists were completed for 93%. GP referral checklist was completed for 78.6%, and the same management checklist was completed by the GPs. So the participants' perspective was that the LHWs, as we call them in Pakistan, are the source of providing awareness and information about hypertension and referral to the healthcare center. Similarly, medicines should be provided to us by the government, as the doctors prescribe expensive medications, which is an extra burden. So we have a lot of overlap of private general practitioners in the same area. For the healthcare providers' perspective, it was that this model is aligned to our healthcare delivery at the district level. The LHW screen the BP during routine home visits. The patients are then referred to the healthcare providers, who would confirm the diagnosis and prescribe the indicated treatment based on the study algorithm. We were trained to monitor blood pressure and to home health education regarding the healthy lifestyle and dietary modifications to control hypertension. We now know what to educate the patients. We are seen as more credible in our community, and people get this service at the doorstep. So this kind of brought up the morale of the healthcare providers in these, and they were very willing to come and learn and change. Similarly, the healthcare provider perspectives, hypertension triage counters and hypertension care coordinators in the government clinics are very much needed in order to curtail the waiting time faced by the patients in the clinics. It could decrease the workload of the doctors as well. So the triage counters, which never existed before, were taken up as a very positive point. So for the scale-up, challenges were, despite a high rising burden of non-communicable diseases, of which hypertension is the leader and should be the entry and pivot point for all NCD interventions, I believe, is not a high priority of the public healthcare program and service delivery systems in Pakistan. And resource mobilization is and strong lobbying is required for the buy-in by the government with support from donor agencies for the scale up of the interventions. So this is where we stand. And we have the same images that you've seen for Bangladesh and Sri Lanka, patients in their homes. And then the small slide, we can talk about it in the question answer sessions. I think because we're short of time, I will end there. Thank you.
Thank you very much. I think there are a few questions from the floor, from people who've been listening and I think enjoying the talks, and there's some very complimentary statements. First question, and I think this is perhaps to you, Tazeen. Question from Donald Morisky. How much of a problem is adherence to the medical regimen? And I think I'd also like to add on to that, not just the medical regimen, but also the lifestyle changes. We didn't hear very much at all about whether people lost weight, whether they did more exercise. So could you respond to that?
Right. So thank you for those questions, and great to hear from Don Mursky here. So I think we measured adherence. We tried to measure adherence to lifestyle changes, and we did measure adherence to self-reported adherence to medications. And what we observed was because of the intervention, there was an improvement in adherence. And it did, I believe, contribute to some of the benefit that we've seen. So it's not just that. So part of the intervention was that the community health workers themselves would go, they would give lifestyle advice. They would also give advice on improving adherence to antihypertensive medication and to statins. We've also taught during the physician training, we taught the physicians not only to prescribe, but also to underscore adherence. So that was also part of the strategy, part of the intervention was to emphasize or underscore adherence, because that is we know that that's a big challenge in the communities. So this is a multifactorial problem. So we did make so some of it, this is a medicine adherence. As far as the lifestyle adherence is concerned, unfortunately, from what we hear back from the qualitative studies, the community health workers will tell you, when you go back and ask the participants, they will say, we changed our lifestyle a big time. And repeatedly, we've done salt reduction, we're exercising more and whatever else. The study, unfortunately, was not powered to look at changes in BMI, changes in physical activity. And so we could not demonstrate significant changes in the lifestyle measures. But the changes were still in the right direction. And I think that, small changes cumulatively, and I think, we're going to talk about the mechanism of effect. And I think that what we are seeing here is probably a combination of the two, or a combination of several things here and synergies between the two. So I think clearly that the benefit here that we are seeing is quite a bit because of medication, increase in medication, increase prescription of medication, which we've demonstrated that there was definitely an uptick in the prescription of medication, in the number of medication use, also adherence, and also lifestyle. So it's a combined effect.
Thank you. That's very helpful. Another question from a colleague from Nepal wanted to know, did non-physician health workers actually initiate treatment for high blood pressure, or was this always done by a doctor?
That's a great question. So the non-physician health worker, and I believe that he is talking about prescribing antihypertensive medication. So non-physician health worker always give the non-pharmacological advice. So I think if you're talking about, for people who had, uncontrolled, but minimally uncontrolled, so less than, 160, they started with a lot of lifestyle education, which is, but as far as prescription is concerned, no. in none of these countries, they're authorized. So I think that was what it was. When we were designing, so I'm going to add here, when we were designing the study, that was one of the things that I think we did consider very strongly. Could we perhaps make a model where they could prescribe under supervision? But I think there is such strong physician lobby in the countries that I think was not going to be possible during the lifetime of the trial. And so we backed off. And I think it's just not, so I think we wanted to go with something that's feasible and that we could scale up easily. So no.
Yeah, okay, thank you. Question to other members of the team. Use of digital technologies and remote data collection, especially in the current COVID times, what do you see as happening in the future? Should we be digitizing all this on mobile phones and uplifting it to the cloud and forget about pencils and papers?
I think this is a great question. And to be very honest, at particularly the program that the health workers are delivering, they are not able to make this kind of close engagement due to COVID at the moment. So it will be a great approach that if we try to integrate some digital technology to augment the Cobra service delivery. And you all may all know that in Bangladesh particularly, that a digital platform has been encouraged by the government and at the community clinic service providers at the grassroots level. They are also being trained for creating a health patient tracking record system. So this is already being introduced in the country. So I can speak from the perspective of Bangladesh. It is a very high time that we try to test digital implementation with Cobra and trial it in our South Asian countries. Thank you.
Thank you. Thank you. Another quick question before we move on to the... Yes, of course.
I mean, I totally agree with what Alia said about digital platforms, because we all know from this study, as well as the feasibility study we did before the large study that we undertook, because remember, this particular Cobra BPS was preceded by a feasibility. In both these studies in Sri Lanka, we found that the rural population was, in relation to the other two countries, was more educated, and they had access to free healthcare. Sri Lanka's healthcare service is free at the point of delivery, and they had access to medicines. But the level of control, as you saw, was very poor. So it shows that this whole loop has to be connected: diagnosis, facilitation of treatment, and then the follow-up. And this kind of home health education and the follow-up that can happen through community health workers through a digital platform, I think, will be a great solution if implemented.
I think I'd agree with that. I think we have to look at hybrid models where it's possible. So it's not everybody is going to be able to do it, but for people who can, there should be this option.
Yeah, and final question, which I think is a really important one, which is to do with the fact that a lot of these people had chronic renal problems, a lot of them had diabetes, and I'm sure a lot of them had mental health problems too, which may have been affecting their adherence to medication, which we know is often the case. Is the bottom line going to be that we try and develop a cadre of NCD workers rather than just blood pressure focused? How do you see things coming in the future? Maybe Professor Amir and Professor Gunawadhana.
Thank you. I think it's a very important question, and I was actually thinking about it because I read it in the chat box as well. So first of all, we didn't follow them long enough. So for renal disease, there has to be a curve, and and mortality secondary to renal disease will take time. But my point is that hypertension, I can tell you, Pakistan in adults nearly 50%. So the leader should be the pivot point of entry and the pivot point. So for all NCDs, I think hypertension should be leading, and it explains and covers most things. People who are hypertensive will become diabetics and dyslipidemic much earlier than people who are controls who are not. So I think it's a fair point of entry, and there is a lot of data, and we can spend, kind of siphon our funds from tertiary care services to taking care of. So in Pakistan, we have free stents, free high voltage devices, which are very expensive, dealing with a few hundred individuals. If we siphon that fund, which comes through the government, to these programs like Cobra, I think we'll be changing the face of hypertension and NCD.
Thank you. Thank you. Fine. Well, if we could move on to that section, and I think Professor Asita, would you like to introduce your colleagues from the Ministry of Health, please? Thank you.
Thank you, Shah. Thank you very much. In the interest of time, we have three panelists, senior representatives on this panel. And in the interest of time, I'll introduce them together. The first speaker is Dr. Vindhya Kumari Peri. She's a community consultant community physician and a senior medical administrator, and holding the position at the moment of Director Non-Communicable Diseases and Director of Policy Analysis and Development at the Ministry of Health. At the moment, she oversees planning, implementation, and monitoring of national chronic NCD and acute NCD prevention control programs at the national level, as well as district levels. The second speaker is Professor Nalika Gunawadhana, a dear friend of mine. She's the National Professional Officer for Non-Communicable Diseases and Health Systems at the World Health Organization Country Office in Sri Lanka. She's a public health specialist with an MD in Community Medicine and degree from the University of Colombo, and she has a master's in public health from New Zealand. The final speaker is from the World Bank, Dr. Deepika Artigala. She works as a senior health specialist in Colombo office with the World Bank South Asia region. And she started her career as a national program officer at UNICEF. And has great experience as a specialist working in many countries, including Afghanistan. And she's been a regional coordinator for UNICEF. And she's experienced in working with Ministry of Health in Sri Lanka for more than 20 years in various capacities, both at national and district level. So these three speakers, Vindhya, Nalika, and Deepika, will talk about the perspectives from Sri Lankan community and health system. May I request Vindhya to start the presentation?
Thank you, sir. Good evening, everyone. So to describe the program for prevention and control of NCDs in Sri Lanka, I would first like to briefly present the burden of NCDs in our country. So according to the Registrar General's data, the 83% of the mortality is due to chronic NCDs in our country. So the risk of premature death from NCDs, that is dying between the age of 30 to 70 years, is 17% according to the most recent estimates, and it's a bit higher for males compared to females. So according to the STEP survey in 2015, as you can see here, the current smokers and current alcohol users were very much higher among males compared to females, and physical inactivity and overweight and obesity are much higher among females. And as you can see here, 1/3 of our sample had never had their blood pressure checked, and over half of the adults with hypertension were only about half on medication. So when we look at the National NCD Prevention and Control Program, it's based on the national policy and the strategic framework of NCD Prevention and Control, which was published in 2009. And later on, we had developed a national multi-sectoral action plan in 2016. So the program target is to reduce premature mortality due to NCDs by 2% annually over 10 years' time. So the National Multisectoral Action Plan for NCD Prevention and Control has 4 key strategic areas: advocacy, partnership, and leadership, health promotion and reduction of NCD risk factors, early detection and management of NCDs and risk factors, and surveillance, M&E, and research. So I would like to describe the NCD policy and the multisectoral plan implemented in Sri Lanka, which is actually the National NCD program. So our National NCD program is governed by the National Advisory Board, the National Steering Committee, and the NCD Council. There are 26 administrative districts in our country, and the district level NCD program is implemented and coordinated by a multi-sectoral steering committee. And this committee is co-chaired by the district secretary and the district director of health services. That is how we take our national program into the district level. And each district has a NCD focal point, a medical officer for NCDs who oversees the implementation of our national NCD program at district level. So those are the main governing and coordinating factors in the national program. If we look at the second strategy, for health promotion, a happy village is established. So the happy village is a volunteer-driven, population-based health promotion initiative. It is a health promoting village setting that encompasses a population that is empowered to address all domains of health, including NCDs. So at the moment, there are over 250 happy villages established in our country among the 355 MOH areas, giving a coverage of over 70%. So that was the initiative for health promotion. When we look at the 4 NCD risk factors, there are several activities implemented at the policy level, regulatory level, as well as at the community level. And our next presenter will give more details about the prevention of 4 risk factors in our country. Our third strategy of the national program is early detection and management of the NCDs. For early detection of NCDs and risk factors, healthy lifestyle centers were established in our country in 2011. They are apparently healthy people, 35 years and above, as well as those between the age of 20 to 34 years with selected risk factors are screened for NCDs. Those who are detected positive at the healthy lifestyle centers are referred to a medical clinic for further management. At the moment, there are over 1,000 healthy lifestyle centers functioning, covering all the primary care hospitals in our country. The national program also leads the development of management guidelines for NCDs and risk factors. We also provide training to relevant staff, ensures essential medicines and technology available at hospitals, especially the primary care level. And we also guide expansion of cadres required for NCD prevention and control. Actually, a new category of nurses called the Public Health Nursing Officers, or the PHNO, was created in 2018, since there is no grassroots level healthcare worker in our country for NCD prevention and control. The fourth strategy is surveillance, M&E, and research. Our NCD surveillance is limited only to the HLCs or the healthy lifestyle centers at the moment. And there is a web-based information system called the HIMS, which gathers data for surveillance. And finally, the monitoring of the national program is done quarterly and annually, and this monitoring is actually happening at the district levels, through the medical officer NCD that I mentioned earlier, as well as by the national directorate, and this is done at quarterly level and also annually. So that is the summary of our national NCD and prevention program. Thank you very much.
So as Vindhya explained, I'm going to explain a bit about how Sri Lanka implements the WHO advocated technical packages to address the risk factors of NCDs. Next slide, please. As you all know, these technical packages, the basis is what we call best buys. The best buys are a set of evidence-based effective population-level interventions to address the major NCD risk factors. And WHO has formulated technical packages, the interventions into technical packages, so that the countries can adopt it based on their needs. To take on a few very main risk factors, as we all know, salt, the dietary salt is one of major risk factors for NCDs in global risk factors for NCDs. And the WHO has advocated a package named SHAE, giving listing the evidence-based intervention for dietary salt reduction, which can be adopted by the countries. So Sri Lanka, I'm happy to say, has adopted this package into a national salt reduction strategy since 2018 and have implemented many of the main strategies effectively by now. To name a few, the country has introduced a regulation to have front of pack labels indicating the content of salt, sugar, and fats in each of the packaged foods as a way of informing the consumers of how much salt which is included in the packaged food using a traffic light system. Similarly, a back of pack label regulation is on the way, giving the more using a nutrient panel, the more detailed scientific information on each of the nutrients included in the packaged food will be displayed, again trying to educate the consumer of the amount of salt and other food ingredients included in the package. A mass media campaign to reduce dietary salt is underway, and also there is work which we have begun with the Ministry of Health, with the formal and informal food industry, trying to address the content of salt and trying to empower the food industry to reformulate foods to contain less salt. The other dietary-related technical package that is advocated by WHO is to address the trans fatty acids, the so-called industrially manufactured trans fatty acids in the foods that we eat. And the package is named Replace. I'm happy to say that Sri Lanka has conducted a landscape analysis of the trans fat situation in the country and is now already in the path to formulate a regulation to eliminate industrially produced trans fats in the near future. Tobacco is a main risk factor for NCDs, as we all know, and the WHO has advocated to the countries the Framework Convention on Tobacco Control, which is a collection of evidence-based interventions that would work to limit the tobacco use among population. And Sri Lanka was one of the countries that signed this convention very early in early years, and several items of this convention have already been implemented in the country. The main ones are listed here, like sales restrictions by way of pictorial warnings, having age limits, and prohibiting sales through vending machines, and implementing tobacco taxes, and having restrictions on direct and indirect promotion of tobacco, and as listed here, imposing ban smokeless tobacco, and so on. The technical package to address alcohol is named SAFER. Again, it is a collection of evidence-based interventions which the country can adopt to reduce the use of alcohol among its population. And again, Sri Lanka has already implemented many of the evidence-based interventions as advocated by the SAFER package, and the main ones are, again, restriction on sales through age limits and restrictions on selected days and times, imposing taxes, and imposing restrictions on direct and indirect advertising. The other main risk factor for NCD being physical inactivity. The WHO has a technical package named ACTIVE, promoting countries to take actions to promote physical activity at policy and regulatory levels. And the country has already designed its own national guidelines on physical activity and sedentary behavior based on the global package, and has implemented some of the main recommendations, like creating user-friendly physical spaces and using the settings approach through schools and workplaces to address NCD risk factors. Thank you, and I will take any questions later on in the panel discussion.
Dr. Deepika Artigala from the World Bank to make a presentation. We have already 5 minutes beyond the closing time, so we're very cognizant of the time.
Thank you for inviting me. Yes, just to reiterate the fact that the NCD, the numbers are on the increase. In light of this increase, and along with the demographic transition that we are experiencing in Sri Lanka, strengthening primary healthcare has been identified as one of the key strategies for health sector development. So although Sri Lanka has a very good track record in preventive care services, the evidence shows that primary curative care services are highly underutilized. So bypassing lower level facilities are more common among certain age groups and sex groups. And particularly the adult men often use secondary and tertiary care services to treat illness and stop them from progressing. But most do not seek preventive care to manage the risk factors or delay the onset of the disease. So currently you see over here the health service pyramid. It is inverted in Sri Lanka. The pyramid is inverted in Sri Lanka. So flipping the shape of this service utilization pattern would provide opportunities for improving the quality of care, also improving NCD prevention and control programs, and thereby increasing the fiscal space of the country. We all know the effective screening and management of NCD are of utmost importance. The study done in Western Province in 2017 has highlighted the importance of continuum of care. So effective management of diagnosed hypertension was recorded in the study as a challenge at that time when the project development, at the time of the development of this current project. So I'm sure with all these current strategies, the things are better than what it was in 2017. Many research and those anecdotal evidences that showed that there are some system issues also that need to be paid more attention, such as poor outpatient department services, fragmentation of care or other episodic care, inefficient follow-up care facilities at clinic, and inefficient or inadequate laboratory services, deficiencies in pharmacy services. So with that, considering all these factors, in 2018, based on the government request, the World Bank has agreed to take forward the Sri Lanka's country engagement in health sector development, identified the primary healthcare system strengthening project focusing on NCD for 2018 to 2023 with an investment of $200 million USD for 5 years. So project development objective is to increase the utilization and quality of primary healthcare services with an emphasis on the detection and management of non-communicable diseases. So empanelment is one of the key features of this project. So population empanelment to the nearest primary care hospital was done considering the road accessibility and other geographical parameters. This was done by the MOH. So this will help people to know the institutions that is responsible for providing care for them and the available services too. An essential component of this process is the registration and issue of the personal health numbers to an identified catchment population of each PM's primary medical care institution. So HLC is also part of these primary medical care institutions. So this will help to screen and to do a systematic follow-up activities in more systematic way at the primary care institution, which includes the healthy lifestyle centers too. So on the other hand, the care providers will know the characters of the population for whom they are responsible, irrespective of whether the individuals seek care from their institution or otherwise. There are some other components, also key thematic areas of this project, such as strengthening the information management system, laboratory services or the laboratory networking system, and also availability of essential drugs for 24/7, and also strengthening the linkages between the preventive and curative care services. Of course, finally, the citizen engagement factors as well. So one of the key indicators of this project is directly related to non-communicable diseases. So this indicator basically is targeting at least 25% to 50% of adults with high risk for non-communicable diseases registered at the primary medical care institution or the HLCs will be managed and actively followed up at the primary care level institution by the end of this project cycle. So that is the expectation. So to facilitate those processes, the government or the MOH is investing the project finances for all 9 provinces. So it is expected at least 550 out of 1,000 odd primary medical care institution. In other words, 60% of these primary medical care institutions will be strengthened in a phased manner, ensuring sustainable people-centered services, providing a continuum of care with a special attention to the National Non-Communicable Disease Prevention and Control Program. Thank you.
Thank you. Thank you very much, Deepika, and thank you very much to all 3 of you, Vindhya, Nalika, and Deepika. Professor Ibrahim, would you like to take it from here and move to the next, because we need to move on now?
Yes, thank you. Well, I think the next speaker is Dr. Abdul Gaffar, Executive Director of the Alliance for Health Policy and Systems Research at WHO in Geneva. He's worked for over 30 years in low and middle income countries, managing research for health, planning, designing, and evaluating national health systems, and teaching health policy and management. So I'm really looking forward to hearing what you've got to say, Dr. Gaffar. Thank you.
Thank you very much, Professor Shah. And I know there are very few minutes left, so I don't have a presentation. So the first and foremost, I think there's no disagreement about the results and the robustness of the studies presented. So there's no question which I want to ask, but I like to have few comments based on the discussion and the presentation. I think there's one issue which we all need to recognize, that when we say evidence-based interventions, what do we exactly mean? And are these interventions which are proven effective to a certain extent, and are they proven effective in all settings? And I think there's a serious challenge and issue when we present different interventions as evidence-based interventions, which are perfect in a biomedical case, but may not be necessarily equally effective into the health system or policy settings. So that's the first point I just want to register. The second is, we have heard about cost effectiveness, and there's a perfect science about cost effectiveness. And again, we undermine the limitation of the delivery systems or the health system when we present the cost-effective intervention. And the people who are familiar, almost everybody is familiar with the DCP results. We gave perfect cost-effective intervention for each chapter. Is it really delivering? Because we look or overlook that how can we really deliver those cost-effective intervention? And we look at some sort of numbers which are important, but does not present the whole picture. It makes a very strong case that what should be the investments we should make, but does not provide the picture. And we saw in at least one of the studies, they said, we have provided 20% of the salaries to the lady health workers. So basically, we have to consider everybody who wants to have a good intervention trial, they are using these like community health workers and provide them some incentives for that particular intervention or a project. And that creates some positive biases, and people do deliver, and we make those calculations, which are not realistic. And we should see what is the total cost and what will happen if the project is not there, how the system is going to pick up the cost. Like we can calculate that, okay, finance will pick up this one. And then we forget where is the fiscal space to add all these additional costs and the benefits. And we have seen, we all after Ebola were saying, oh, these fragile states, which was West Africa and some other Middle Eastern countries where we have the war, but the whole West, with full respect, have fallen on the face. There's no country which was a resilient country. And we started teaching and promoting resilient health system after Ebola, but we forgot what do we mean by resilience, but because we have to follow the fashion, so sometimes we follow the fashion. So here again, the point I'm trying to make it, I think we are promoting absolutely fantastic results of the biomedical intervention, but we are saying it's a systems and policy research. With due respect, I think this is not a systems and policy research. It's a perfect intervention trial. It's a perfect clinical trial. However, we have considered that what could be the policy and the systems repercussion, and those are important, but I think we need to move forward. And the reason I'm saying is this is one mindset which we have the researchers, but there's a prevailing mindset within the policy and the decision maker there. They happily think that evidence-based medicine, we should all agree there's no way to look beyond. If there's nothing which is evidence-based, we should not promote, implement, regulate, whatever we have to call it. But the policies and decisions could be only evidence-informed. I have yet to see a Ministry of Health, and I work almost for the larger part of especially the low and middle income countries, south part of the world, yet one Ministry of Health which uses research evidence to make most of its policy. The research may be only 5% of the overall policy and decision making in the Ministries of Health. The reason I'm happy to bet that is there how many secretaries of health in the South do look at the Lancet or the New England Journal of Medicine results. These are important results, but I have not seen yet one Secretary of Health who said that, oh, I looked at the Lancet, I looked at the New England Journal of Medicine, and this is what we would like to do it. Yes, maybe if there's a cardiologist who's front of that Secretary of Health, definitely they would like to do it. If there's a friend in the Ministry of Finance, a peer, yes, they would like to do it. So I think the point, because we are finishing the time, we have left 1 minute in our allocated time. I just don't want to raise only the problem. The problem is every day, especially with open access, literally hundreds and thousands of articles are published. How many of those articles are either known to or presented to the policymaker? Because there are some good results. And that is our responsibility as the researchers. And we have our own limitation. We have been trained to publish into the Lancet, into the New England Journal of Medicine, and the BMJ anywhere. But we have very limited capacity to present and have a policy discussion or policy or research interface, or we are not establishing any platforms. We are trying at the WHO. There's an enhanced effort to have the policy dialogue, and we are working with our colleagues, especially in the NCD department and the cluster. And that is like first time in the history of WHO, we have appointed more than 100 national professional officers in many WHO country offices. And we are happy to see those things because we have been promoting these best buys. But do they fit into the local context? They fit as an academic exercise, but we have to see how can we implement those best buys into that particular context. It may be like a state in India, it may be a province in somewhere else in Burkina Faso or Bangladesh, but we need to look at that. How can we increase the opportunities and interaction between policy and the researchers? And one way is if we can embed policy and the system research as part of the program and the policies, then I think the dissemination and the uptake of the research would be much higher. We are working with many countries and many other departments, especially within WHO with the NCD colleagues, that we are trying to embed research. Having said that, we need to appreciate the limitations of the system, and we should not get worried. We should know what we can achieve, what we cannot achieve. But as the results of acceptability from many of the colleagues have shown into the country setting, I think there's a great hope. These are all very capable, reputable leaders in their own settings, but also in these countries. And I think that is where we need to invest more and more time and resources. How can we make a change at the system level and scale those interventions? So thank you for this opportunity, but I would like to continue this discussion and dialogue which we are having in the WHO at the headquarters, but with this bright team of the Cobra. And this is a fantastic study, very important results, but I think we should push. How can you make a change in the system and policy? Back to you, Professor Shah.
Thank you very much for some very insightful experiences and messages for all of us. Just as you were talking, the thing that really sprung into my mind was that in Britain, we have the National Institute for Healthcare Excellence. I was a non-executive director for that organization for a few years. And it was one of the ways in which one could bring science and the evidence into policy is having an independent institute that was not of government, was not of the scientific community, but was informed by the scientific community. And NICE International was a spin-off from this, and I did some work with them in India on health technology assessments. And I think there are some tools that we can use, and I think the type of research we do makes a big difference. So research that is embedded in countries, across regions, that has good links with the local healthcare providers is already a bit further down the road than special models with special staff to do the interventions and so on. So very, very insightful. Other comments that people would like to share with Dr. Gaffar? Okay, well, we've probably got to, I know we have got to the end of the time that was allotted for this webinar about 15 minutes ago. I think I'll pass over to Professor Tazeen Jaffar and Professor Asita Da Silva to do some winding up. Thanks very much.
Thank you. Thank you, everyone. And thanks for the insightful comments. I think what I'd like to share at the end is are the recommendations from our group, from our study group. So let me share that slide. Okay, so I think, all the presentations today that we've heard from our Sri Lankan stakeholders, from our panel members, I think were very, very insightful. And I think collectively the Cobra BPS group, based on our study findings and based on the other work that's going on, we'd like to recommend that the South Asian countries prioritize hypertension and NCD control and prevention via population and systems level approaches. The government departments would work together with the health academics, professional organizations, and NGOs to strengthen capacity of hypertension care delivery, regular monitoring and evaluation of hypertension control. And I think this is kind of in line with what Dr. Gaffar has mentioned as well too. I think we need to work together to embed programs. And then the strong legislation for tobacco control. There is a lot of evidence, obviously, for legislative approaches, and here I'm going to again use the word evidence. So we do have strong evidence for legislative effects of tobacco on impact. For the other interventions in how they impact the different countries, I think it's variable, and it does depend upon country to country. The programmatic efforts should explicitly focus on urban slums and in rural populations where health systems are the weakest and the populations are most at risk. And we recommend that Cobra BPS be integrated, the strategies into health systems. Specifically, we engage community health workers. There's now loads of evidence, not just from our study, from other studies, that community health workers, that we engage them in prevention and control of hypertension, including blood pressure monitoring, lifestyle counseling, and in the package of services, and that those should be linked appropriately to the primary care services. I think and I agree with the comment raised about the resources, but I think that fiscal space need to be created. I think countries now need to sit and think, what is it they need to, it's about the health budget, but also about priority setting, and that exercise needs to happen now. So I can't underscore the fact more. Hypertension is and continues to be, and is the rising is the most important single leading risk factor for mortality. Regularly train the physicians and updated management of hypertension. Give visibility to hypertension NCD control by establishing counters, space, whatever you call it, is just giving visibility. And again, this is something that came up from the ground level up. So this came from the health systems to us. These are the district managers who told us to do this, and it works. And then compensate the district health system for the additional task. And so again, that's about the fiscal space, and everything that adds value is going to cost something. And that's something that I think the provincial leaders, and it needs to happen at the provincial level. That's where it needs to happen. And maybe we need some champions at the district level, at the provincial levels. And that's how systems work. We don't wait for centrally, but at least locally, and maybe demonstrate, and then it becomes a mirror for others to follow. Maybe that's the way it's going to happen nationally. So make antihypertensive and cholesterol lowering drugs available at low cost in the primary care settings. We're not saying free. Free would be great. Sri Lanka provides it free. But if you can't make it free, then at least make them low cost and subsidize it substantially. Increase emphasis on hypertension management knowledge and training skills at the undergraduate and postgraduate level, the continuous CME curriculum of health professionals. And I think, the landscape has changed, and we shouldn't follow the kind of training that used to happen 20, 30 years ago. It needs to change and evolve according to the disease burden. Cobra BPS complements. Yeah, so I think that's really important. It does complement existing WHO and government initiatives. Everything that we heard at the policy level, I think this is a systems approach that's going to complement. We recommend to broaden the scope of the facility level initiatives, all the good things that we heard that the World Bank is doing in Sri Lanka. I think that's absolutely outstanding. And I think that kind of work that's at the facility level, and I think the WHO is doing with the Global Heart Program, that's great to strengthen the primary healthcare facility. But it needs to, we need to think about what are the additional components of Cobra. It is the community health worker component, and that needs to be added. And say, okay, well, there's the outreach to make it the full 5-component program, and that's going to give the meaningful blood pressure reduction and cardiovascular risk reduction for greater population level impact. So I think these are some basic recommendations that our group has collectively suggested and would like to recommend as an outcome of this forum. And then finally, I would just like to thank everybody, all the participants, all the speakers, and my co-host Asita, and the team from Sri Lanka, and our team from Singapore, especially Cecile and others who've really worked over the last several weeks to make this happen. And for everybody who's participated, we hope to continue this dialogue with the stakeholders and for everybody else, and take it to the next stage and scale up. Asita?
Yeah, thank you. Just a quick word on this. It reminds me of a conversation I had with Eric Finkelstein when he was doing the economic evaluation, when he was presenting the dollars and the cents to us. And I remember quite clearly Eric telling me, this should not be looked at an expense, but the cost or the expense to buy good health. And in that context, I think we've done quite a significant job or remarkable job in bringing or highlighting community level hypertension care through this multi-component intervention can achieve. And for that, I'm very grateful to the participants of this study, as well as my colleagues in the regional health centers, the community health workers, regional directors of health, the NCD, medical doctors, and so on, who made it possible along with our coordinators, as well as the collaborators in Singapore, Bangladesh, and Pakistan. And thank all of them, plus all the people who attended this webinar for now just 2 hours. Very much. Thank you very much for Sri Lanka.